Read home. It's all good. Oh, I'm not muted.
Hello and good morning. I'm Dr. David Pedler, Scientific Director of CIMVHR. Thank you for logging into today's symposium on chronic pain, called Comprehensive Person-Centered Pain Management, Common Themes and the Way Forward. Before we begin, let's acknowledge the Indigenous peoples of all the lands that we are on today. While we're meeting virtually, I would like to take a moment to acknowledge the importance of the land, which we each call home. We do this to reaffirm our commitment and responsibility in improving the relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. Before I introduce our symposium moderator, I will invite Dr. Stéphanie Bélanger to say a few words.
Bonjour et bienvenue à ce symposium sur la douleur chronique. Je suis Stéphanie Bélanger, professeure au Collège militaire royal du Canada, fondatrice et directrice scientifique associée de l'Institut canadien de recherche sur la santé des militaires et des vétérans. Nous sommes honorés d'organiser ce symposium avec le Centre d'excellence sur la douleur chronique pour les vétérans canadiens. Et nous souhaitons que nous allons pouvoir vivre une expérience enrichissante.
Hello and good morning. I'm Dr. David Pedler, Scientific Director of CIMVHR. Thank you for logging into today's symposium on chronic pain, called Comprehensive Person-Centered Pain Management, Common Themes and the Way Forward. Before we begin, let's acknowledge the Indigenous peoples of all the lands that we are on today. While we're meeting virtually, I would like to take a moment to acknowledge the importance of the land, which we each call home. We do this to reaffirm our commitment and responsibility in improving the relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. Before I introduce our symposium moderator, I will invite Dr. Stéphanie Bélanger to say a few words.
Bonjour et bienvenue à ce symposium sur la douleur chronique. Je suis Stéphanie Bélanger, professeure au Collège militaire royal du Canada, fondatrice et directrice scientifique associée de l'Institut canadien de recherche sur la santé des militaires et des vétérans. Nous sommes honorés d'organiser ce symposium avec le Centre d'excellence sur la douleur chronique pour les vétérans canadiens. Et nous souhaitons que nous allons pouvoir vivre une expérience enrichissante et que nous allons pouvoir vous inspirer dans vos recherches futures. Bon symposium.
It is now my honor to introduce Lieutenant General Retired Eric B. Schumacher, 42nd U.S. Army Surgeon General and former Commanding General of the U.S. Medical Command. CIMVHR had the pleasure of welcoming Lieutenant General Schumacher to Forum 2019, where he shared his expert knowledge on chronic pain with our delegation. Now I'm thrilled to have him back in our presence to continue the conversation. Lieutenant General, thank you for joining us to moderate this session.
Thank you, Dr. Pedler, and good morning to all. Welcome to this very special webinar that's aimed at sharing our collective experience, our wisdom, and the many questions that remain about how best to care for our Canadian and U.S. service members, our veterans, and the families of those with chronic pain. I want to thank Dr. David Pedler and his team at CIMVHR for the invitation to be with you today. I was privileged to be with you a year ago at this time, and I'm so glad to see this growing. As you heard, I'm Dr. Eric Schumacher. I was privileged to be in service as the 42nd U.S. Army Surgeon General and commanded the U.S. Army's Medical Command. I have a passion and an enduring commitment to help those who are suffering from pain, especially those who have served in uniform in all eras and who have defended our two nations, and the families and caregivers of those veterans. I'm privileged to serve as the moderator for today's unique international forum. You in the audience can best join us by your presence here and your questions and observations, which you can provide through the website. To begin our first session, it's my pleasure to introduce Dr. Friedhelm Sandbrink, the U.S. National Program Director for Comprehensive Pain Management and Opioid Safety for the U.S. Veterans Health Administration. He is an innovative clinical leader. He's been a champion for our stepped care model of care, which, among other ideas and programs, he's going to discuss with us today. Dr. Sandbrink, the microphone and the camera are yours.
Good morning. I'm really excited to be here, and I think this is a wonderful collaboration between Canada and the United States Department of Veterans Affairs and the Department of Defense. My name is Friedhelm Sandbrink. I'm a neurologist and pain physician and work at the Washington, D.C. VA Medical Center. And I'm also the National Program Director for Pain Management and Opioid Safety for the Veterans Health Administration within the Department of Veterans Affairs. And I'm going to give you an overview about our experience with biopsychosocial pain management here in the United States in the VA. As you can see here, I don't have any relevant disclosures, and of course this is my personal opinion and does not reflect the official views of the Department of Veterans Affairs or any other federal agency. Just a little bit as a background. In the United States, we have about 20 million veterans, and almost half of them are enrolled in the Veterans Health Administration. And we have 6 million patients who get, or veterans who receive their regular care in the VA, primary care, enrolled in primary care, and 2 million have at least one pain diagnosis. But only a fraction of these can actually be seen within our pain specialty clinic. The 2012 data shows about 6% of veterans actually make it to pain specialty care. So really the majority of pain care is done within the primary care environment. We have a few data about the prevalence of pain in veterans in the United States. This is not just specifically about veterans in the VA, but all of the United States. And as you can see here, and that's shown on the left side, severe pain is about 40% more common in veterans than in the non-veteran US population. And this is true for women and men, and this is true also across the ages. And in particular, if you can see on the right side, for younger veterans, the odds ratio of having severe pain is about 2 or 3 times greater in younger veterans, that is here the age of 18 to 39, than in the non-veteran population. Looking more specifically at veterans who are enrolled in the VA, we know that from prevalence data in 2008 and follow-up in 2015, that actually the mental health conditions and pain conditions have become more frequent. This is in part because of the VA population being enriched by veterans who have mental health comorbidities due to the care that we provide. And, just one example here on the left side is how these mental health and pain conditions often occur together. This is a sample from veterans who had been deployed in the OIF setting. And as you can see, the majority of patients had both pain and PTSD, and many of them also had mild TBI conditions. Our prevalence data also shows that about 1 in 3 veterans has a chronic pain diagnosis and 1 in 10 has severe persistent pain. And just as another example of the frequent comorbidity of pain and mental health conditions is in our behavioral autopsy report, where they're looking back and trying to understand in patients who had completed suicide, what were risk factors? The pain is the identified factor. More recent data shows that the opioid overdose deaths occur also more frequently in veterans and in the non-veteran population. This is consistent with prior data as well. The most recent data that's published is in 2016, and we know that about 3 to 4 veterans die in the United States every day who are receiving care in the Veterans Health Administration, and that's about 7 to 8 veterans every day. And the majority is, the deaths are related to synthetic illicit drugs, the fentanyl products in particular, very much mirroring the experience, I think, for the whole US population. So our comprehensive opioid strategy started in 2013, but I want to emphasize here, this is obviously a talk less about our opioid strategy, but rather about our non-pharmacological modalities and our biopsychosocial approach. And we understood very much that expanding access to those modalities, non-pharmacological, integrative health modalities, had to be an essential component of our opioid safety initiative. And it really reflects the way this paradigm shift away from opioid therapy, with all the shortcomings that are listed here, towards multimodal, integrated, and team-based pain care. And when I mean team-based pain care, I'm talking also about the collaboration that happens between the primary care pain teams and often the specialty pain teams at facilities. This very much mirrors what has been published by the Department of Health and Human Services, Pain Management Best Practices Task Force report in 2019. As you can see here, there are 5 pillars: the medication therapy, restorative therapy, interventional pain therapy, behavioral approaches, and complementary and integrative health approaches. And they really have to be in conjunction, applied in conjunction. They have to be made available to the patients and to veterans in particular, according to the individual need. And we make all of these modalities available within the VA system. But it has to be a biopsychosocial assessment as well as a treatment model, with the goal to improve the pain experience, physical functioning. The emphasis is on the functioning itself, on the quality of life and the activities of daily living. But it has to be individualized and patient-centered. Obviously, we're talking about these 5 pillars, and it really depends on the individual assessment, what is right for the patient when you choose the medication or the therapeutic approach. And you do this in a patient-clinician relationship that is based on mutual trust and respect, and really results in a therapeutic alliance. Within the VA system, we have established a VA stepped care model for pain management with our National Pain Directive published in 2019, which also emphasized the foundation in the biopsychosocial pain care. And the foundational aspect is really a whole person, a whole health approach. And we see this relatively broadly, knowing the emphasis on appropriate weight management, nutrition, exercise, conditioning, and then also stress management, sleep, and other factors that are listed here. The majority of pain care happens within the primary care environment, our medical home that we call the patient-aligned care team. And we have integrated mental health within the primary care setting, as well as direct access to a whole list of treatment modalities, including PT and the integrated modalities. But this is complemented, obviously, according to risk for the patient with higher comorbidities, complexity, or high risk, and access to specialty care settings that I will talk a little bit more about. But as I said before, it's a collaborative approach. We are approaching this not from the more traditional way with a referral sent to a specialist who sends a report back to primary care, but rather the involvement of the pain specialty team really needs to be targeted to what the specific need is for a patient. And it's meant to be a collaborative approach, that it's a joint pain care plan that involves both the primary care team that the patient often is very comfortable with and the pain team. seeing each other as partners that work together. In 2017, the Veterans Health Administration issued guidance in regard to the mandated minimum composition of pain teams at all facilities of all major VA medical centers or parent facilities. And this included a pain medicine provider, integrated access to addiction medicine, integrated access and consisting of behavioral medicine, at least one evidence-based behavioral therapy, and that's, cognitive behavioral therapy for chronic pain, or acceptance and commitment therapy, or mindfulness-based stress reduction, and an integrated access to a rehabilitation medicine discipline. And all of these are part of a fully designated pain team. And we did an internal audit of this in 2019, and 140 facilities were sampled, which are our parent facilities. 95 said that they had a fully implemented, fully designated pain management team. 39 said that they had a partially pain management team with one or more provider possibly missing from this list. And at that time, 6 facilities had not implemented a pain team yet. We also mandated the function of these pain teams, including an evaluation of patients for complex pain conditions, but also the ability to provide follow-up care if clinically indicated, and actual prescribing of medication, not just making recommendations in regard to a consultative role, but actual prescribing, which is really a mandate out of the Comprehensive Addiction and Recovery Act in 2016, which state that at all VA facilities, these pain management teams have to be available to assist primary care and other providers with opioid prescribing and to take over prescribing if clinically indicated. In addition, there are other components that are highly recommended as key elements for successful implementation of pain management teams, including an e-consultation process, obviously immediate consultation to assist our primary care providers and others. In the last 6 months or so, really, we have seen a great expansion of telehealth modalities. Interventional pain care is obviously important, a tool in our armamentarium to deliver high-quality pain care, but it wasn't mandated for all pain management teams, among others, because we knew that it may not be feasible to have an intervention provider at smaller facilities, and we work in conjunction with providers in the community who can deliver this particular modality for us. We also expect a primary care pain champion integrated within the primary care setting who knows about the pain treatment approaches and is our liaison to our pain specialty team to be available at all facilities. A recent survey of VA facilities shows that we have about 102, this is the most recent data, pain clinics or pain centers. And over time, what we see is that there's really an increased complexity and expansion of the care that they provide. And you can see this here in 2010, the majority were pain clinics, but not really interdisciplinary or pain centers. And over time, this has really shifted towards a higher complexity of care that is being delivered. I want to mention also that we have a large number of interdisciplinary pain rehabilitation programs in the VA, really that provide functional restoration approach. These are programs with a defined entry and exit. Many of them, 20 programs, have accreditation by the Commission for the Accreditation of Rehabilitation Facilities, CARF. But we also have about 24 programs that don't have CARF accreditation, but also provide a similar approach, usually a behavioral therapy approach together with delivered in conjunction with a physical therapy or rehabilitation approach, often involvement of case management, medical management as well in a comprehensive way, with different intensities here depending on site. We do have one inpatient program, which is at the Tampa VA. It's currently on hold, and it's delivered over virtual care only with the COVID crisis. But the expectation is that it will eventually resume again. And here I'm showing the list of the sites in the United States who have a CARF-accredited IPRP program. In regard to the actual non-pharmacological pain treatment modalities that we deliver in the VA, we held a state-of-the-art conference in 2016. The output of this is listed here, just in this diagram. So within the behavioral and psychological therapies, I already mentioned CBT, ACT, and mindfulness-based stress reductions as behavior treatment modalities that have evidence for successful improvement in patients with pain conditions. In regard to exercise and movement therapies, it's yoga, tai chi, and exercise modalities, and manual therapies, including acupuncture, massage, and spinal manipulation. I also want to mention specifically that in regard to CBT, the VA has issued a manual that is in the full 12 sessions used typically by our pain psychologist within those IPRP settings and other pain specialty care clinic settings usually. And we have now also a briefer version of that that can be applied right within the primary care environment, typically by the mental health providers embedded within primary care. That's about 30 minutes each for 4 to 6 appointments. So it really can help to bring this to the patients, to the veteran early on in order to prevent chronification and to allow for early access and easy access to self-care and self-management. I just want to give a couple more examples of our team-based approaches. This is here a team that we mandate also at our facilities, teams that come together to review patients that are on opioid medication and are believed to be a potentially very high risk. We have a predictive analytic tool. It's called a tool to help our facilities to stratify those resources to those veterans at highest need. It's called the STORM tool, the stratification tool for opioid risk mitigation. It uses predictive analytics to identify the patients who are at very high risk for either an overdose death or suicide death in the next year. And what these teams do is that they come together once a week, once a month, depending on the need of how many veterans need to be reviewed, to look at the care of these veterans and find out if we can improve them further. They have interdisciplinary membership consisting of primary care, pain specialty, mental health, substance use disorder programs, suicide prevention. Typically, pharmacology pharmacists are on board. And they review the care and make recommendations, and they write that into the chart and get, if needed, other stakeholders on board. And the examples here, patients on high opioid dosage, opiate benzo combinations, all this contributes to risk and may be used for these reviews. Recent data, I may just add that on, shows that these reviews truly have saved lives of veterans with reducing the risk of those patients where these care reviews have happened and the coordination has happened, we will have more refined data about that, but it clearly is very strong signal that we have that this has made a difference and saved lives. But we also have a team-based approach in regard to the stepped care for opioid use disorder treatment. We integrate, as I mentioned, assessment and evaluation for opioid use disorder within our pain teams and within primary care. And lastly, I want to just report about a team base in regard to our Scan Echo teams, which is Specialty Care Access Network with extension for community healthcare outcomes. This is modeled after the New Mexico School of Medicine. It's really a tele-video setting that brings primary care providers with specialty care remotely together, where they can discuss the consultation regarding a particular patient. And it obviously provides care for that veteran and guidance, but more so it's a way to teach and educate our primary care providers. And this does make, all these efforts do make a difference, right? There's a publication that we had recently that shows that opiate prescribing has decreased, and at the same time, psychosocial treatment modalities, physical therapy, which is in green line here, has increased. And on this slide, it's a complicated slide. In the interest of time, I'm not going to go into details here, but what you can see is that the greater the implementation of physical therapy or occupational therapy, the greater the availability of specialty pain clinics, and the greater the implementation of CIH modalities at a facility, the less likely the patient will be started on opioid medication. Which is really part of our biopsychosocial approach. And I'm closing with a summary here that we know that, it has to be, a biopsychosocial care has to include a self-care, self-management model of care, in our setting, very much based on a whole health approach. We certainly rely on primary care delivering the majority of our pain care, but they are supported by interdisciplinary pain management teams at our facilities with different modalities available: telehealth, e-consultation, VA, echo. It's essential to integrate mental health providers, both within the primary care setting as well as our specialty care setting. I gave you some examples of other team-based approaches that we have in the VA, including our large network of interdisciplinary pain rehabilitation programs, many with CARF accreditation, and we apply the similar approach also to opioid use disorder. And with that, I want to thank you for your attention. I want to encourage you to visit our website, which is listed here under the va.gov/pain management website. We have lots of resources, both for providers as well as veterans, an overview about opioid safety initiative, but especially now in the setting of the COVID crisis, we have made a lot of modalities available and access and to links that can be applied remotely for virtual care delivery. And with that, I'm going to hand it back to Eric and I'm open and looking forward to your questions. Thank you.
Well, Freedom, thank you very much for a really clear and informative talk. I must say I've heard you speak in many other fora, and I'm privileged to be a part of the VA now, but you teach me something every time, and I hope folks have a chance to look at some of the references you've introduced. You talked about this complex mix of problems facing most U.S. veterans with chronic pain in the United States that requires the biopsychosocial approach. We're going to hear about a very similar array of issues in Canadian veterans when Dr. Ramesh Zacharias speaks. I'd like to begin by how you brought together the caregiver, support staff, and the veterans themselves under this comprehensive approach. You talk about and you emphasize the role of evidence-based, non-pharmacologic complementary modalities or therapies in this approach that are integrated with the more conventional practices, including interventions, procedural interventions, and drugs. How much resistance have you encountered from clinicians and others about the perception that these complementary practices, like acupuncture or the adaptation of conventional acupuncture to what we call battlefield acupuncture that started in the DoD, which is a refined modification of auricular acupuncture, mindfulness meditation, and yoga, the perceptions that these aren't based in good science and in good clinical trials. Have you encountered that perception?
Yeah, we certainly have. And I think it's something to anticipate. I think there are a few aspects that I want to emphasize. On one hand, as we roll this out, I think it really is important to concentrate on the integrative modalities that have the best clinical evidence. So I think, it's a shotgun approach that everything is being promoted. I think you have to emphasize what makes the most sense for patients and what makes most sense for clinicians to utilize. And I think it was really helpful that in 2017, the Office of Patient-Centered Care, Dr. Klegler can talk more about that because it's in his program, that they issued a direct guidance about which of these CRH modalities have clinical evidence for support and should be the ones to prioritize for integration in clinical And the other emphasis that I said is the SOTA, the state-of-the-art research conference, that again provided a summary of the evidence, specifically also from the VA perspective, and resulted in a publication with Dr. Klingler as the first author that shows this. Providers will maybe pick one or the other that they feel more comfortable for, and that is okay. But also, I think we should emphasize that we not just have this rolled out as making CIH modalities available. It really, the whole health approach is a much more comprehensive approach that transforms how we deliver care. And Ben will certainly speak to that.
Yes, I'm glad you brought up the state-of-the-art conference that I think David Atkins put together in your research community. I was published in the Journal of General Internal Medicine as a special appendix to the journal. And it's been repeated now several times in the US. Most recently, I believe the National Academy of Medicine held a consensus workshop as well that emphasized which of the modalities that we think of as many of them quite ancient, but with good underlying scientific evidence, and that's being amassed even more by the National Center for Complementary and Integrative Health of the National Institutes of Health. Like to turn for a second to, and one other comment I'd like to make, Frieda, and I love the fact that the step care model begins with self-care for the individual suffering from pain, because I think we oftentimes have given short shrift to these complementary integrative health modalities because we reserve them as almost a court of last resort. And they've been, I think, marred by the fact that many times they're the most difficult and most resistant, and oftentimes are patients we ourselves have contributed to injuring through adverse effects and the like. And if we can push that into the self-care and primary care arena, we might see a much different outcome for many of these. So I appreciate that comment. I'd like to turn for a second to the fact that, like the US Veterans Health Administration system that you're working in, our Canadian colleagues really rely on the primary care sector, physicians, nurse practitioners, PAs, and others, to provide pain care, often in very remote sites. You talked about the ECHO program, and maybe you can expand upon that a little bit, but how have you in the US Veterans Care System tackled these hurdles of remote sites and better educating the primary care sector? Thank you.
Yeah, so, I mentioned briefly the ECHO program, and, for pain management specifically, we originally had 7 sites that provided, an ECHO program to support their primary care providers, typically regionally. This actually has evolved over time. There was one in particular in Richmond, which became such a popular place for others to participate in that it really became a case-based educational series. And we've taken this now to a weekly and case presentation that we disseminate from our national pain program nationwide. We also have developed, and we are working on other approaches. So co-visits at your facility with a patient and having integrated a remote participation by one of our specialists that may help you with our conversations with a difficult, challenging patient. So that's something that, so rather than the scan echo, which is a visit without the patient participating, we fear that we've heard this, is that often it's like, the providers say, I may know what to do, but it would be good to see this actually done in a patient. I have a particular patient, I'm just not quite comfortable having that conversation all alone. So having somebody else who just joins your conversation, even if it is remotely, elevates us also from a patient perspective, because they say that I really get heard. This is not somebody who's talking about me, but we have a conversation that includes me. And one particular other aspect that I want to emphasize is that we also build this network of primary care pain champions. So every facility is mandated to have a champion within the primary care environment, one of the primary care providers who co-leads their peers to support them in regard to pain management. And they work very much closely in collaboration with the specialist, but you don't need to reach out of your environment. You have your own team member who knows about how to do this administratively at your facility and who's really experienced in having difficult conversations and guiding you along. So I think these are two particular efforts that I think have been very successful for us.
Yeah, thank you. We only have about a minute and a half left, but I wanted to emphasize, and I caught that in your presentation, that the ECHO program and the outreach from the primary care to these specialty clinics, 140 or so in number, is not to consult refer the patient to the specialty clinic. It's to educate the primary care community about how they might manage that patient and keep that patient within their primary care team.
Exactly.
One question, if we could answer it in a minute or so, that I think is very important from one of our viewers is how functionality in areas of life like employment and recreation and social integration and the like are managed. And this might be a time to bring up the Defense and Veterans Pain Rating Scale that changed the dialogue to one that looked at functionality.
Yeah, so I think the emphasis really is much more on function rather than on pain scores. As you mentioned, Eric, I think the Defense and Veterans Pain Rating Scale is clearly, I think, one effort to tie a functional component to the actual number of 0 to 10, but then also in the supplementary questions to truly ask about pain interfering with relevant, quality of life aspects, sleep, mood, stress, contributing to stress, as well as general activity. In the VA, so while that is developed in the DoD and with the VA involvement, we also have our PEC score that many use in the VA that also emphasizes the interference with enjoyment of life and general activity. And as we will be moving forward to our joint electronic health record, we will have all of this included as a standard. The DVPRS will be our standard in regard to pain scoring moving forward.
Well, thank you so much for a really informative talk and contribution. We're going to hear more from you later today when you come back on our panel. It's really my pleasure and privilege now to introduce the Executive Director of the U.S. Veterans Health Administration Office of Patient-Centered Care and Cultural Transformation. That's a big mouthful. Dr. Ben Kliegler. Dr. Kliegler is going to speak today on his office's and the VHA's role in promoting a transformative embrace of whole health for U.S. veterans, an approach that relies heavily on this biopsychosocial approach to health and well-being, including pain. Dr. Kliegler, thanks for being with us today. The podium is yours.
Good morning. My name is Dr. Ben Kliegler. I'm a family physician, and my position is the Executive Director of the Office of Patient-Centered Care and Cultural Transformation at the Veterans Health Administration. The VHA is part of the United States Department of Veteran Affairs. I'm looking forward to talking to you today about whole health, which is the biopsychosocial model of pain care that we are moving forward in the VA. In the U.S. Veteran Health Administration, we are responsible for caring for veterans across the country, and our job in my particular office is to advance something we call the whole health system. That's going to be my focus today. I do want to just share a tiny bit about the VA. There are roughly 140 VA medical centers. There are over 1,000 outpatient sites. We care for, on a regular basis, roughly 6 million veterans, all ages, all conflicts. And we have roughly 350,000 employees in the department. So very large system. We are a national system. We are the largest integrated federal government healthcare system in the United States. So we have a great opportunity to advance this type of approach to pain. Just to share our definition with you, whole health is an approach to healthcare that empowers and equips people to take charge of their health and well-being and live their life to the fullest. This is something that's evolved over the course of a number of years in the VA and also builds on the integrative health approach that's been spreading across the US and Canada for a number of years. This is an image that's very important to what we talk about when we talk about whole health and really illustrates why this is entirely a biopsychosocial model of care. This is something we call the circle of health. And as you can see, the veteran, or me, anyone in fact, is at the center. A crucial part of the model is mindful awareness. And then surrounding the patient are all the domains that go into a healthy approach to self-care. And this applies, today we're talking about pain, but this really applies to everyone, whether they have pain, whether they have another chronic condition, or whether they are well and just looking to become more well. And as you can see around this circle, many of the elements of the biopsychosocial approach are represented here. Spirit and soul, family, friends, and coworkers, personal development, as in what work, etc. do I do? And then in addition, a number of particular areas of self-care, working the body, food and drink, sleep, etc. Then surrounding that is the treatment team, and surrounding all of that, which I think in some ways is very important, is this concept of community. And I'm going to talk more about that as we go along, but that's a very important part of the whole health model. So a lot of the approach really relies on these questions that you see here on this slide. How are all these areas interconnected? So in other words, your health is not just about your disease. Your health is about you as a whole person, your family, the community that you live in. And we're really working towards expanding the model of what a healthcare system can do beyond excellent disease-oriented care, which is something the VA has excelled at for a number of years, expanding that to really moving forward with the person at the center towards what matters to them in their life and what's most important, and a real whole person approach to care. So we use this circle to help start the conversation. Sometimes what we talk about when we're teaching about this to clinicians is we talk about changing the conversation and moving from just talking about your pain, just talking about your diabetes or your mental health condition to talking about you and how the management of those things can be supported and improved by a whole person approach. This is the way we're delivering this care. It's called the whole health system. And the whole health system consists of three main components. The pathway is the opportunity for a veteran to talk with a peer, a fellow veteran, somebody who understands what they've been through in terms of their time in the military, and share with them just that. What matters to you most in your life? What do you care about? What do you need your health for? And what are the areas of that circle that you might start to need attention, that where you might want to pay attention and start to work on moving yourself to a stronger place? Then the well-being programs are where we offer the complementary integrative health approaches. I'll say more about that in a minute, as well as health coaching, lots of health education and self-management skills like yoga and Tai Chi. And then the whole health clinical care domain is where we continue with the excellent disease management and preventive care that we currently do, but our clinicians know how to, quote, change the conversation so that what's important to the veteran is always at the center. So we're very ingrained now in the VA's strategy. We're in the VA strategic plan, the 5-year plan that governs what the department does. And as you can see, specifically refers to whole health, focusing not only on treatment, but on self-empowerment, self-healing, and self-care. We also have a lot of support from Congress. And what I'm going to talk with you about most of my time right now is the outcomes of a demonstration project that was mandated by this piece of congressional legislation, the CARA Act, which was passed in 2016. And among many other provisions related to pain, care, and addiction, what the CARA Act did was mandate that VA stand up a pilot program on what happens when you integrate complementary integrative health and whole health into the care of veterans who are suffering from chronic pain. As part of this, we were required to prepare and submit a report to Congress in July of this year regarding the preliminary outcomes from this experiment at what we call the flagship sites. So that's what mostly I'll be talking to you about today. But very important to us is the fact that we have very strong support in Congress, not just through the CARE Act, but a number of members of both the House and the Senate who feel that ensuring that a whole person approach is moved forward with the veteran population is a real high priority. This is a map of the states, as you can tell, and really you can see these are all the VA sites, inpatient and outpatient, where whole health is happening. This has been spreading over the course of really the last 6 years or so under the rubric of whole health, but really this process has been ongoing in the VA for probably, it's safe to say, 15 years around the concepts of patient-centered care, moving forward the biopsychosocial model, and applying complementary and integrative health approaches to the care of veterans. One thing I do want to mention that may be important is that the VA in 2017 made a decision, a policy decision, to cover the evidence-based complementary integrative health approaches as part of standard medical benefits. And that's a very, in my view, forward-thinking decision, which has allowed us to really push forward in integrating these things into pain care and integrating these things into the whole health model. So what I'm presenting to you now is the outcomes of the preliminary evaluation at our 18 flagships. The flagships are dispersed across the country. There's one in every VISN. The VISNs are what we call the regional networks of the VHA. And each VISN identified one flagship to begin this 3-year demonstration project to see what happens when veterans with pain have access to whole health. You can see here the services that are part of this model and that we looked at as part of this outcome evaluation. The complementary and integrative health services on the left are the ones that are evidence-based to be covered by the VA medical benefits. Chiropractic has actually been covered for a much longer period of time, since 2005. In addition to those services, we're looking at what we call the core whole health services, which include things like coaching, the pathway services, which, as I mentioned, is where a veteran gets to meet with a fellow veteran to start the conversation, and then many of the educational groups. So this is what we're looking at. And as you look at the data that comes, that we'll be following, you'll see that we divided the population that we were looking at into what we call comprehensive whole health users who had 8 or more whole health visits over the course of the period of evaluation versus people who had just a bit, between 2 and 8, and people who had none. So this evaluation, I just need to say, was done in close cooperation with some wonderful colleagues from VA Research, from the Health Systems Research Division, and we are really honored to be able to be part of this. So one of the first things we looked at was utilization across the 18 flagships. And the question we were looking to answer here really was, well, are veterans really going to be motivated to participate in this? Is this an idea that we have, but not something that's really going to appeal to veterans with chronic pain? And what we found was, over the course of the 3 years of the evaluation period, which we've just concluded, 31% of veterans with chronic pain engaged in some kind of whole health service at the 18 sites. Now, clearly not all of those were comprehensive users, but that's the number of people who were at least touched by the whole health system across the 18 sites. And let me correct myself. That's actually the number as of the end of 2019. And that number has increased now between that time and the current moment. So one flagship had as many as 55% of veterans, but basically what this utilization data answered for us was the question of, is there demand from veterans for this kind of approach? The answer is yes. So now I'm going to share some of the preliminary outcomes. And I won't go into detail on this slide because I have graphs to show you detailing a number of this, but you can see declines in opioid utilization, improvements in how veterans felt about their care, how engaged they felt, improvements in how engaged they felt in life, and improvements in perceived stress, all very important components of really helping people become more whole and more able to move towards what matters. So this was the data we found on opioid utilization. This was obviously a big headline for us because this is a huge priority in the country and has been a particular priority in VA. So what you can see on the left, you can see the black bar, which is veterans at the flagships with chronic pain who did not participate in whole health. their average opioid dose over this study period declined by 11%. So VA, like many other health systems, is working hard to curtail opioid prescription. So the overall average is a decline of 11%. But when you look to the right here at these two bars on the right, which are the comprehensive users, 8 or more visits, you see that their decline over the study period was 38%. So in other words, 3.5 times the rate of decline in average opioid dose in veterans who are using the whole health system. And this is looking at a total sample of 114,000 plus veterans across the flagship sites. Now, I will say it's important to note that the data here, as well as the rest of the data I'm going to show you, this is observational data. So because this approach, the whole health system, is being deployed on a large scale, we're not randomizing, it's not a clinical trial. So the possibility that this is what you would call correlation as opposed to cause and effect definitely exists. And that just needs to be said when we look at this data. A second finding that was very important to us, and I'll explain why, is the two right-hand bars here capture something called the Life, Meaning, and Purpose Scale. And this data comes from a very large mail survey that has gone out to 24,000 veterans with a diagnosis of chronic pain across the 18 flagship sites. So we're asking them about 20 minutes worth of questions, which is a combination of a number of different validated measures, including the Life, Meaning, and Purpose Scale. This preliminary evaluation is based on the first 3,200 plus veterans who had a baseline and at least one follow-up point. We're going baseline 6 months and 12 months. And now our cadre is up to about 7,000. So we're going to redo this analysis in the coming months, and we'll have hopefully even more data. But to come back to the Life, Meaning, and Purpose Scale, you can see that comprehensive users had substantial movement in the positive direction on life, meaning, and purpose. Now, why are we so attached to this? We think that this is one of the critical parts of the whole health model, is helping people identify what is their purpose in life, what matters to them in their life, and then helping that be the focus of their work with the healthcare system and their planning and their goal setting and where we help them to move. And life meaning, loss of meaning and purpose in life, we know to be a risk factor for suicide. And as I'm sure you know, the veteran suicide rate is a huge concern here in the VA, a huge concern in the country. Now, we don't have the power to say whether we are actually having an impact on suicide yet, but the fact that we're able to show that we're influencing what might be one of the mediators of suicide risk, I think is very important and very promising for the future. What I want to call your attention to on this slide is the third from the left. This is the perceived stress scale, which is a 4-item question, validated measure, basically how much in control or out of control of your life did you feel in the preceding week. And again, as you can see here, the more whole health services a veteran used, the more improvement they had on the perceived stress scale. This correlates in all kinds of different studies with overall quality of life. And so we find this is an important finding. Now, interestingly, if you look over here, this is the pain scale, or one of the pain scales we used. And you can see, although we see some positive movement, not in all the groups and not incredibly dramatic. I think what's important, though, is we don't see a worsening. And we put this in the context of a 38% decline in average opioid dose. So despite opioids being reduced, the experience of pain in the veterans is not getting worse, and for some of the population, it's getting better. This is the veteran perceptions of care, and what I want to highlight here is the right-hand column. This is a goal-setting measure, so basically a measure of did the veteran feel that they were helped to set goals and move towards those goals, which clearly in a biopsychosocial model of pain and a whole person model is very important. We're not just looking at disease outcomes, we're looking at where you want to go in your life. So very positive movement in the comprehensive whole health users on whether or not they felt they had been helped in setting goals and successful in moving towards those goals. Also very important to the model is it wasn't a question of a particular goal. You have to exercise more, you have to lose weight, you have to participate more socially. These are goals that the veteran sets as part of the process. And that's where we find the value. That's what we feel is most important to measure. I want to comment just briefly. We also looked at employee impact of involvement with whole health. So on the all employee survey that the VA does every year, we asked employees whether they were involved with whole health at their facility, and the scale ranged from 1, which is I'm not involved in whole health, to 7, which is I'm responsible for all the whole health activities at my site. So we were able to quantify how engaged an employee was with whole health. And what we found is a number of very substantial benefits for employees in terms of engagement and burnout, et cetera. So why do we think this is important? We think that employees being knowledgeable and having the opportunity to experience this whole health approach, both is very important because we feel then they'll be in a position to take better care of veterans, but they'll also be in a position to really share this and encourage more and more veterans to engage with the system. So this is just to show you what are the measures that moved in employees. You can see burnout went down, turnover intent went down, the notion of VA as a best place to work went up. So all the measures that correlate with employee engagement, employee satisfaction really went in the expected direction for employees who were more involved with the whole health system. So let me just summarize briefly. As far as the whole health approach to care in the VA, which is really I would say maybe expanded version of the biopsychosocial model, we really have discovered or observed, let's say, some very impressive preliminary outcomes. We did report this up to Congress in April of 2020. So we've shared this with Congress, we've shared with the leadership in the VA, and we really do have a lot of ongoing support. We're looking forward to continuing to look at this data as the program continues to expand. We've moved from just an emphasis on the 18 flagships to 37 new sites that are deploying whole health. And really, this is something that's spreading across the country. I did want to share a recent special issue of the journal Medical Care, which focused on the implementation of complementary and integrative health approaches in the VA. Lots of good information here. The link is there. This is all free for you to download and read. I would really encourage people to look at this and take away some of the lessons that we've been learning. And with that, I think I'll conclude and look forward to hearing any questions. Thank you very much.
Well, Dr. Klieger, thank you so much for a really encouraging presentation about the impact of the U.S. veterans' whole health system on improvements in pain outcomes for those who are using that approach. In the interest of transparency, I should explain to people that although I still work very closely with the U.S. Department of Defense on their through the Defense and Veterans Integrated Pain Management team, I'm also now a part-time VA employee. In fact, Ben is my boss, and I'm a big fan of this whole health. I think this is one of the most transformative, programs. It's hard to call this just a program, but transformations that has occurred within a very, very large system of healthcare in the United States, and it's a privilege to be a part of it. You know, you were very careful to remind us there toward the end that these outcome measures that have been observed in the first 18 months of the program across 18 so-called flagship VA medical centers in the 18 specified Veterans Integrated Service Networks or regional commands, these observations are just that. They're observational at this time, and they're really not subject to the same rigorous analysis of clinical and statistical proof. As you pointed out, there could be correlation and not causation at this point. What plans do you and the VHA have for expanding the whole health system, and when do you think we can see, as a consequence of that expansion, a more rigorous analysis of those outcomes?
Thank you, Eric. And yes, if you ask me questions that are too hard, you're in trouble. So just keep that in mind.
But that's a really good question. Basically, that was that analysis. The timing of that analysis was mandated by the fact that we had a report to Congress due this past spring. So that meant we pulled down the sort of database basically 2 years into the project and ran that analysis. Now that we're a year farther along, rather than the 3,200 veterans that went into that sample, we now are up between 7,000 and 8,000 respondents on that survey. So one of the strategies for improving the rigor basically is we will have more veterans in the sample, and so that will help a bit with some of the issues around correlation and causation. A bigger strategy is that we're also proceeding with, or not we, but our HSR&D, our research colleagues are proceeding with building statistical strategies to kind of match up other groups of veterans in comparison to the whole health cohort. So propensity scoring and other statistical methods that we've done some of that already, in particular for the opioid analysis. And I will say that the more rapid decline in opioid utilization did hold up when it was sort of tested with more rigorous statistical methods and a comparison group. So that's going to be a lot of the work that happens over the next year or so, basically, is kind of building out comparison groups so that that larger sample then has a something to compare it to. I think the other thing that's happening is you asked about the future of whole health. I mean, VA is really spreading this now across the whole system. And one of the great things about VA and its sort of concept of a learning healthcare system is that we can access lots of data from the corporate data warehouse and look at changes in veterans who have used whole health compared to veterans who haven't, on a much larger scale than even we were just able to do at the flagships. So we're looking to do more of that work in the coming year and sort of expand the reach. The last thing I'll say is that that evaluation did focus on veterans with pain because that is one of the most important areas, obviously, but that also was one of the focus areas of the legislation that mandated the project, the CARA legislation. So we really had to focus our assessment on veterans with chronic pain, but we're equally interested in what the impact is on mental health diagnoses and on other conditions. And as the sample gets bigger, we'll have more patients with a variety of comorbidities or other diagnoses that we can look at to see. We have a picture of how it may work in people with pain. What about people with pain and mental health? What about specific subpopulations? What about women veterans? What about people from other underrepresented minority groups? Do we see a difference in how the impact shows up? So I think there's lots more that's going to come out in the next year to tell us more about how this is really working.
One of our viewers has written in, first of all, saying very impressive outcomes, Ben, and very encouraging. How is the veteran and family peer support program operationalized in the whole health model?
Well, let's see. So there's a little bit, just to explain some of the terms, there's a specific job in the VA that's called a peer support specialist. I'm not sure if the person is referring to that component. I'm going to assume that you're not. That's a particular role that's been developed within mental health. So if we're talking about in a more larger sense of working with fellow veterans as part of your team, basically it's really at the center of the model. So the first place it happens is in that pathway group or that pathway experience that I talked about. And that may be a 2-hour introduction to whole health session that's led by a fellow veteran or someone else who is trained to lead that session. Then you might move on to a Taking Charge of My Life and Health course, which is a 6 to 9 week course, basically usually done in a group, but can be done individually. And it's led by a trained veteran facilitator, can be done virtually. These days, a lot of them are happening virtually. And also in that group, you're encountering kind of the peer experience, not just with the facilitator, but with the other veterans in the group. So I think right at the basis of it is this idea that the conversation about what's important to you, in some ways, the best place to start that conversation is with a fellow veteran. And so we have a lot of former military service, but a lot of veterans who've been trained in how to facilitate these groups and how to bring that conversation to their fellow veterans. As far as families go, this is a really growing area. I mean, people may know that VA is really expanding its perspective on how we bring the family into the care. It's critical to the whole health model. And if you go back and look at that circle of health that I showed earlier, family and friends is one of the areas that's most important. So off the bat, I would say that when the veteran facilitator, the health coach, the clinician has a conversation with the veteran about what areas do they want to work on strengthening in their self-management, what's going on with their family is kind of front and center. And if you think about it, for so many people, what gives their life meaning and purpose is tied up with their family and what they hope and want with their family. So I think it's absolutely intricately connected with the whole conversation. Last thing I'll say about that is one of the, upsides, I guess you could say, or silver linings of the pandemic is we've ended up putting a lot of our veteran resources online, including many well-being experiential resources. And what this has done, since it's outside the VA firewall and available to anybody, is make these opportunities, whether it's a guided imagery or a chair yoga or music, whatever it might be, make it available for veterans to do with family and friends. And that's something called the #LiveWholeHealth campaign. And I'd encourage anybody to take a look at it. There's lots and lots of great resources there. So that's another place where the virtual environment allows us to bring in family members a lot more easily.
Great. We only have about 2 minutes left here, Ben. I've got some great questions. One about lashing up your work with Dawn Vogt at the National Center for PTSD and BU. I think I'll hold that question until the last panel today.
Okay.
In the meantime, could you gave an overarching look at how big the VA is and how many medical centers are involved. Roughly, how quickly do you think that whole health is going to move through the VA from 18 sites to where every facility is involved in this?
Well, I'd like to say tomorrow, but I think you know better than anyone perhaps what a challenge it is changing what's really a huge system. So I think one might say it's going to take several years really to reach every facility, every outpatient facility, become available to every veteran. I think what we have in our favor is a lot of support from VA leadership, from our current executive in charge, Dr. Stone, and Secretary Wilkie. They've both been very supportive of this, and I think see it as one of the things that makes VA unique. So obviously that helps move it along, but at the same time, standing up new services and changing the way people look at their role, clinicians in particular, as more oriented towards helping create well-being as opposed to just treating disease. That's a long journey, shall we just say. So I think we're on that journey, and exactly how many years it's going to take, I'm not sure, but the good news is the momentum is really strong at this point.
Great. Well, thanks very much, Dr. Kligler, for all your leadership and for this encouraging news, and for your sharing that with us today. And we look forward to having you on the panel later in the program. It's really my privilege now to move across the border, and that's not an easy task in these days of COVID-19, to introduce one of the premier leaders and clinical innovators in pain care for Canadian veterans, Dr. Ramesh Zacharias. Dr. Zacharias is the CEO and medical director of a new bold initiative to build a network of comprehensive pain care, which is centered at McMaster's University Medical Center, which many of us know as a center for evidence-based care going back decades. And Dr. Zacharias' Chronic Pain Center of Excellence, or what is known as the CPCOE. He'll describe in his presentation the history of pain care, both in the US and in Canada, the rapid development of this new CPCOE, and introduce a special guest with us today, a Canadian veteran who has really courageously agreed to share her story with us. So with that, I'd like to have Dr. Zacharias take over the microphone and the video.
I'm Ramesh Zacharias. I'm the CEO and President and Medical Director of the Chronic Pain Center of Excellence for Canadian Veterans. I'm also the Medical Director of the Michael G. DeGroot Pain Clinic at Hamilton Health Sciences. I want to take this opportunity to thank Dr. David Pedler and his team at CIMVHR for inviting me to talk today about the Canadian perspective on pain management in veterans. I have no conflicts of interest to disclose for this presentation. We will focus on three objectives. Firstly, we will identify the magnitude of the problem of chronic pain in Canadian veterans. Secondly, we will explore the history and models of pain care that have evolved from a medical interventional-based model to person-centered, complementary, integrative pain management. And finally, I will share the journey of one of the female veterans we treated last year at the Michael G. DeGroot Pain Clinic. In 2016, Veterans Affairs Canada published the Life After Service study. The objective of this report was to describe the health and well-being of the 60,000 regular force veterans who released from service from 1998 to 2015. The findings suggested that chronic physical health conditions were 2 to 3 times more common in veterans than the general population. 41% had chronic pain or discomfort. 50% of female veterans had chronic pain, and 79% of those who attributed their health conditions to their military service had chronic pain. "63% with chronic pain had diagnosed mental health conditions. And of those with mental health conditions, 91% also had a chronic physical health condition. 62% of those who were diagnosed with mental health conditions had chronic pain, and 57% of them had activities reduced by pain." I have treated veterans for the last 8 years and have observed that the practical reality is, unfortunately, chronic pain and PTSD are two sides of the same coin. Having identified the magnitude of the problem, I would now like to bring a historical perspective to the evolution of treating chronic pain over the last 60 years. The early dominant voice was that of Dr. John Bonica, who served from 1944 to 1947 in the U.S. Army. His treatment of so many World War II veterans inspired him to dedicate himself to understand and alleviate pain. Dr. Bonica played a significant role behind the formation of the International Association for the Study of Pain, IASP. The IASP is one of the leading voices in the world for pain research and treatment. In December 2012, IASP surveyed interdisciplinary pain management programs from around the world and concluded that most critical is the understanding that chronic pain is a disease of the person and that a traditional biomedical approach cannot adequately address all of the pain-related problems of this patient population. Over the years, the approach to pain management has shifted from injections and medications to a person-centered, holistic approach to include physical, psychological, medical, and complementary therapies. While many programs provide interdisciplinary treatments, they vary in duration, disciplines involved, and levels of comprehensive integrative pain management. In the December 2012 issue, IASP published the review of pain management in 45 countries. Their conclusion was, of all approaches to the treatment of chronic pain, none has stronger evidence bases for efficacy, cost-effectiveness, and lack of iatrogenic complications than interdisciplinary care. In the IASP review, the interdisciplinary care with the greatest success included medication management, graded physical exercise, and cognitive behavioral techniques for pain and stress management. The interdisciplinary program at Hamilton Health Sciences, which has been treating veterans for over 30 years, was initially developed by Dr. Eldon Tunks, who modeled his program based on what Dr. Bunika advocated. Today, the model is being delivered at the Michael G. DeGroote Pain Clinic in Hamilton, Ontario. Treatments offered include personalized case management, daily follow-up, focus on goals and function, one-on-one care with a psychologist, occupational therapist, yoga, tai chi, woodworking, pool therapy, physical therapy, medication management by a pharmacist and a physician. The interdisciplinary pain program at the Michael G. DeGroote Pain Clinic at Hamilton Health Sciences is the in-person 4-week, 100-hour program. The team involves 8 different disciplines and was previously offered only in person. With the onset of COVID-19, the program was modified to be delivered online. This model emphasizes the dynamic relationship between the biological, psychological, and social factors when addressing the issue of chronic pain. The self-reported results of those who have completed the 4-week program suggest improved mood and anxiety, fewer negative thoughts, and better coping self-statements, increased willingness to use self-management techniques, increased acceptance of pain, increased use of relaxation and exercise to manage their pain. As a consequence of the various new strategies that they have learned through the program, they were less guarded in their movements. Because of the success of the program at McMaster University and Hamilton Health Sciences, Veterans Affairs Canada awarded us the Chronic Pain Centre of Excellence for Canadian Veterans on July 29, 2019. The combination of over 45-year history of evidence-based care at McMaster University, along with the experience of treating veterans for the last 30 years, as well as the creation of the Chronic Pain Network by Dr. Norm Buckley through a Canadian Institute of Health Research grant, all played a critical role in the award of the CPCOE to McMaster University and Hamilton Health Sciences. The center was launched on April 3, 2020. CPCOE operates as an independent, not-for-profit organization with McMaster University and Hamilton Health Sciences as the 2 stakeholders. In November 2019, we convened a strategic planning meeting with veterans and their family members suffering from chronic pain. Representatives from Veterans Affairs Canada, researchers, and clinicians to seek input on the vision and mission of the CPCOE. Our vision is improving the well-being of military veterans and their families suffering from chronic pain. This will be delivered by fostering a national network of interdisciplinary pain management centers using research and evidence-based strategies to care for military veterans and their families. Early on, we made a commitment to ensure that veterans played a key role in all aspects of the organization. We immediately convened a veterans working group and subsequently traveled coast to coast to meet veterans and visit interdisciplinary pain clinics. 3 of the 7 members of our board are veterans. Last month, we had our first meeting with our 11-member Advisory Council for Veterans, who played an important role in determining our research priorities that I will discuss shortly. On the basis of our consultations, we have established 4 pillars for the organization. They include leadership on a national basis, research priorities that will be determined through veteran engagement, identifying evidence-based pain management that will be delivered through a national network of pain clinics. The CPCOE will be responsible for the training and education of the interdisciplinary teams. On the basis of the various consultations, we developed a conceptual framework. At the very center of the framework are veterans, spouses, and their families. Surrounding the veterans and the families are 3 domains that the Center of Excellence will use as guiding principles. Firstly, the research priorities will be determined by the Advisory Council of Veterans that will meet on a quarterly basis. Secondly, we have commenced the creation of a national network of interdisciplinary clinics who are committed to a complementary integrated pain model. The third domain will be started in the first quarter of 2021 with a focus on education of veterans and their families and also clinicians to ultimately influence policy to ensure evidence-based pain management for veterans closer to home and in a timely manner. The underpinning of these domains is an informatics platform that will not only link the clinics, but have the potential of being embedded into the electronic medical records of these clinics. We are currently pursuing research priorities that have been approved by the Veterans Advisory Council, starting with identifying the tools to measure the 7 domains of well-being. In addition, we will be studying the transgenerational impact of chronic pain on veterans and their families. Chronic pain affects 40% of male veterans, while it affects 50% of female veterans. We need to study the impact of gender on the statistically significant difference in pain among male and female veterans. Finally, over 10,000 veterans in Canada are having Veterans Affairs Canada approved cannabis for a variety of medical conditions. We are proposing establishing a data registry to track what conditions are currently being diagnosed to receive cannabis and monitor the benefits and potential harms of medicinal cannabis. Finally, the transition from military service to civilian life is often a challenge faced by most veterans. We intend to work with all the stakeholders in developing a seamless transition. I would like to close my talk with an example of a female veteran with chronic pain. Michelle was a 49-year-old female veteran when she was assessed at the Michael G. DeGroot Pain Clinic on October 17, 2019. She was initially injured during basic training in 2004 when she suffered a fractured pelvis and injured her left knee due to a fall. Since that time, she has progressed to develop significant pain in her neck, head, pelvis, and left knee. This has had a profound effect on her sleep, mood, and personal relationships with her husband, family, and friends. As is often the case with other veterans suffering with chronic pain, she tends to socially isolate and suffer in silence. The interdisciplinary assessment involves an occupational therapist, a psychologist, and a physician. In this case, I was the physician involved in the assessment. The assessment is almost 4 hours long, consuming the entire day. The remarkable finding among the 3 health professionals was that Michelle did not stop crying throughout the assessment. She was completely broken, both physically and emotionally. After completing the 4-week interdisciplinary program, she wrote this poem, which I have asked her to read for us today.
Note to self. Quickly fixed with crazy glue, broken but still pushing through, trying to live a simple day, unable to keep the pain at bay. Uncontrollable tears, understandable fears, invisible pain, sadly too real. So many like me are dealt this raw deal, but never too late to take control and render care to my hurting soul. Slow down and take another break. Don't delay, get some heat on that ache. Smell the fragrance of the trees, and on my face, feel the fresh breeze. Calm breath, calm body, calm mind. To my dear self, I will now be kind.
Michelle, thank you for your courage and resilience. You are truly remarkable. To all the veterans, thank you for your service. Aux vétérans, merci pour votre service.
Well, thank you, Dr. Zacharias. That was really very helpful, and certainly the final words of Michelle were very moving. Michelle, who's with us today, is going to join us on the panel that we'll have immediately following the question and answer period for Dr. Zacharias. Thank you again, Michelle, for being here. Ramesh, you've talked about disseminating best practices, both conventional and complementary ones, some quite ancient and traditional, some emerging as we learn more about how the brain processes chronic pain and the role of associated injuries and behavioral health problems, as Michelle's case illustrates. Can you explain how the forum today and perhaps future fora, like the ones you're going to be hosting in November and December on a series of Wednesdays, fit into your overall strategy of finding the best care for your Canadian veterans?
Thank you for the question, Eric. I would like to remind you that when I first met you last year at the CIMVHR conference, and I said to you we were in the process of establishing the Center of Excellence, your comment to me was, learn from our mistakes. I took it as learn from your experiences. And so today is a good example of our commitment at the Center of Excellence is to learn from anybody who is currently treating veterans, whether that's in Canada, in the US. We have started a dialogue with the UK, France, Belgium, Australia, and New Zealand. So we want to be able to not try to invent solutions, but to integrate solutions, whether they're on the traditional model or the non-traditional model. And what's critical is that not only look at systems that work, but engage with veterans at the start. Because at the end of the day, these are the people we're trying to serve. So within the organization, we have made sure veterans are fully embedded in every aspect of our organization. And one of the most exciting things for me was convening the Veteran Advisory Council, where we will bring forward to them research topics we think that would be relevant. They give us input, and the areas that we're pursuing this coming year have all been directed by veterans. And it's not only important to find out what the research is showing, but historically, it takes between 12 to 18 years before evidence comes into practice. And that's too long. So one of the systems we're trying to use is what was developed in Europe, which looks at the rapid recommendations for treatment models. So one of my colleagues has done a rapid recommendation on cannabis use that will be published in the next 2 months, which will talk about it. So we want to use forums such as this, advisory council from veterans, use rapid recommendations to be able to implement not just traditional models, but non-traditional models.
Great. Well, we've had an outpouring of some really good questions coming from our audience, and some I might have to hold for our panel in a few minutes, but I think this first question is really very insightful and one that we encounter in the US as well. The viewer asks that the US VA programs use the term family and friends to encompass all veteran situations, inclusive of those who are single and without a defined family. I'll just intercede that, the US military is about 2/3 to 3/4 married, but that still leaves 1/4 to 30% of, especially our younger soldiers, sailors, airmen, Marines, without a conventional family. what we learned is everybody's got a family, even if it's a cat or a dog, but especially their veteran and active duty service colleagues, as was mentioned by Ben earlier. Has the CPCOE considered doing the same, using an all-inclusive term even for the single veteran or military member?
Yeah, I think it's part of the dialogue we currently have, both internally and externally. The one thing that all of our staff and our board will be getting trained in sex and gender-based analysis. I think it's extremely important that we not just focus on the veterans and their families, but the fact that sex and gender plays a significant role in being inclusive. And so most of us have gone through that training. The rest of the team will. And so every research project that we do moving forward will have to address this issue of sex, gender-based analysis. And so the traditional family has changed. Those who are fighting today are different than they were before. And what we want to do is to meet their needs wherever they are.
I think this next question really speaks to the issue of how the work that's being done within the military and the veterans communities and caregivers is influencing the general population's approach to pain. They ask, how is the veterans chronic pain program at DeGroote different from their quote regular stream? That is what other patients are receiving. How much cross-fertilization is occurring?
So we have two different programs at the DeGroote, one of which is funded by the public system, and the other one is funded by people who are involved in motor vehicle accidents, workplace-related injuries, and the veterans fall into the second program. So usually when we're treating that subset of group, which are injured workers, motor vehicle, and veterans, they're all being treated together. So it is not an exclusive program for veterans. It's a program that includes people who have been involved in accidents as well as workplace-related injuries.
Great. This is a good question, and you talked about the fact that you have a CPCOE and a PTSD COE, and both are flip sides of the same coin, as you pointed out. How do they interact with one another within this network approach that you have adopted in Canada?
So the PTSD Center of Excellence was stood up 2 years prior to us. So they started 2 years before we were launched. We work very collaboratively with them. And we also work with CIMVHR, who are hosting this conference. We are the three research institutes that the Canadian government has funded: the PTSD in Ottawa, CIMVHR at Queen's, and us at McMaster and Hamilton Health Sciences. So we work, today's an example. We're hosting this together with CIMVHR. And so we have meetings scheduled with the three groups to make sure that the veterans are treated in a very holistic approach by all of us.
Is the network that you're setting up that will go out into the hinterland, so to speak, does it overlap with similar networks that are being established by these other centers?
So the history for what is referred to as the operational stress injury clinics, which were launched 10 years ago, literally 8 years before the Center of Excellence for PTSD, are already established. But these 10 centers operate independent of each other. What we're doing is we've taken some of the models from them and frankly created a new 2020 model where the research centers will be working closely with those centers that are delivering care. And so I think over time, the ideal model would be to be co-located with the OSI clinics, or operational stress injury clinics, as well as the chronic pain clinic. We currently have one location like that at Saint-Anne in Quebec. And so ideally, we would expand that particular model because we're treating the same set of patients.
Terrific. I surmise from this question that you have a Veterans Advisory Council. Is there diverse representation on that council? I assume that means both from the veteran population and advocates for veterans, as well as perhaps the practice community.
So the Veteran Advisory Council was just launched a month ago, and there are 10 of them. The majority of them have chronic pain. We have 8 men, 2 women. We will be looking at expanding that over time. But these veterans are not just veterans, they're actually veterans who are also pain patients. So they have lived experiences that go 20 years, 30 years, and as short as 10 years. Eventually, we will expand that particular group, but we started with them, and they're the ones who will help guide us in determining what research priorities we should set, and frankly, what the direction of this organization should be to meet their needs.
Ramesh, we only have about a minute left, and I'm going to pull several of these questions out into the later panel, but which will start shortly. But real quickly, the U.S. talked about, the USVA talked about covering these complementary modalities such as acupuncture, yoga, meditation, eye rest. Is the Canadian system also covering these complementary modalities?
I think over time they could do better. Certainly they're covering massage in some cases, but I think the other complementary modalities will over time, I believe, become part of the lexicon, and that they will get covered. Certainly when they're in our program, we are providing these Tai Chi, yoga, as well as woodworking and pool therapy, and that's part of the fee that we charge Veterans Affairs Canada.
Terrific, thank you. Well, thanks very much for a really informative presentation, Dr. Zacharias. I love how these two worlds above and below the U.S.-Canadian border are so similar in both the challenges and gaps and what are provided, but also the approaches, which I think is what our ambition was from the beginning. We're going to move now to a panel of all of the presenters today. I will serve as the moderator, and you'll see our veteran person. I like that even better than patient. And that's the ambition of all of us, is to keep our persons from becoming patients if possible. Michelle, thank you for joining us today.
It's an honor, sir.
Yeah. And Michelle, I can't thank you enough for joining us. I think we all believe very strongly in how important it is to hear your voice and the voices of all of our veterans who have a really unique story to tell us. And as I think you've heard, hopefully, from our presentations today, every one of our veterans at the center of this has their own story and has to be attended to in a tailored approach. I'm going to roll over some questions from the earlier presentations that I thought could be applied. The first one I think is a great question. All of them are great questions, I should say. But veterans as a whole and service members as a whole have a kind of popular cultural impression of being relatively conservative when it comes to the treatment modalities and approaches. And as this questioner asks, are very unlikely to be open to the quote new age hippie kinds of treatments like yoga and meditation and others. Real quickly across the board, and Michelle, if you want to answer this, you're perfectly welcome to, but I'm going to have some questions, as you know, for you directly. How have you found your veterans populations and even the active military, if you have experience with them, being receptive to these complementary practices? Maybe we can start in Canada.
Yeah, so I think yoga has been part of our program for, I would suspect, almost 20 years. So it was not new. one of the new modalities we introduced probably about 4 or 5 years ago was Tai Chi. And so for a lot of the people who were coming to the program, they were used to yoga, and then Tai Chi was something new. And what's been fascinating is you would think that veterans would not be, especially male veterans, would not be too much into yoga and Tai Chi. But the number of them that once they get a grasp of it, they find out it's a great way for them to be able to deal with acute flare-ups. So rather than reach for a bottle of pills, they can do their deep breathing exercises, their stretching, their yoga, and their Tai Chi. So I would say there has been very good acceptance among veterans for it, because as long as it works, that's what they want.
Yeah.
And I know Michelle, who participated in our program, did participate in those two modalities as well.
Ben, you, Friedhelm, what are your experiences with U.S. veterans?
I would say no problem with uptake. I mean, I think some of those statistics I showed you from the flagships about the proportion of veterans with pain, I think when it comes to treating chronic pain in particular, people are just ready to try anything. There was an early on, a lot of places called yoga, they gave it new names like warrior movement and, other things that were going to be more acceptable. But actually, I will share that one of the folks on my staff, who's a colonel in the reserves and a yoga teacher, is currently involved in a pilot in the Army where they are teaching yoga postures as part of basic training. And in fact, teaching drill instructors, if you can believe it, how to reinforce the yoga postures in their trainees. So I don't see much trouble with the veterans. I think in some ways the longer journey is with the clinicians who, in some cases are not quite aware yet of the level of evidence that's accumulated for some of these therapies. So I think that's in some ways a bigger barrier than the veterans.
Friedhelm, is that parallel?
So, yeah, just to add on, I mean, obviously, I do see a lot of patients where it is challenging to convince them. We have a lot of patients still that are very much medication focused, that approach this from a very biomedical approach. And that's part of what we are trying to do, right? And I think that's why it becomes so important that these modalities and the support of these modalities is so much integrated into what is maybe superficially more acceptable. For instance, if the physical therapist talks about how good an activation and a home exercise program is that includes yoga and some therapeutic exercise and then develops it from there, that increases acceptability. Right. I think for the younger veterans, for us, it is good, and it's good to see that they often now come from the DoD with their first experience. We're not starting from scratch, which maybe with the older, veterans that graduated basically or left the military, many more years ago. So I think, but in the very end, it comes back to all of us speaking the same language, right? If everybody from the receptionist where you sign in to everybody on the pain team and you're in primary care is very open to this and approaches this in a supportive way, then it becomes normalized. I think that's really what we're trying to do, make sure that everybody, whether that's a psychologist in the CBT group, the physical therapist, or just anybody else, a social worker, that they all emphasize the importance of integrating such modalities and that people can do that on their own, right? Then that's when we are successful.
Yeah, And again, in the interest of complete transparency, I'm married to a yoga therapist, so I've been inculcated with yoga for a very long time. In fact, she was one of the inspirations for my getting involved in this whole area of compound integrative health 10, 15 years ago. I can tell you within the U.S. military, you hit the nail on the head, Friedhelm, and that we are a continuum. So things that began in the active duty phase of a veteran's lives spread over into the VA, and that receptivity, I think, does begin in the active duty. I'm privileged to sit along with Dr. Kliegler on the National Advisory Council for the National Institute for Complementary and Integrative Health, the NCCIH, one of the 27 institutes, centers and offices within the U.S. National Institutes of Health. And they focus on these complementary and integrative health practices. A number of years ago, they were willing to split out in their biennial or their every other year surveys of the reception and use of complementary practices, the military community and military family and military service members. And what they found, and it was no surprise to us, is that actually the receptivity to the use of these complementary practices is higher than the general public. And some of that, I think, begins because chiropractic came into military hospitals and the VA in the mid-90s. But I think also because the military in the U.S., like Canada, is exposed to many, many areas of the world in which these practices are commonplace. My own wife, Friedhelm, was exposed to yoga and acupuncture during one of our tours in Germany, and when she went to German practitioners. But there are also marriages with Asian spouses. We have a large number of new immigrants that enter into the services, sometimes to accelerate their citizenship. And so they bring with them attitudes about these complementary practices that are quite tolerant and accepting of them, I think, as a group. And so I'm not surprised that within the VA and possibly also the same experience in Canada, that people are far more receptive. You have a very, very multicultural community in Canada, and I'm not surprised by the reception people have. And at the end of the day, I love the comment that both you, Dr. Zacharias, and both of you have said, people are interested in things that help. And if it helps them, the stigma associated with it is not that important. I'm going to move to another, I thought, fascinating question that had to do with looking at the multi-dimensionality of chronic pain being influenced by PTSD and behavioral health problems and the like. And the viewer asks whether it's directed at the CPCOE, but I think it really could also fit for the VA community in the US, since much of it originated in the US, is how does the concept of moral injury fit into the care of these pain sufferers?
So I know the other Center of Excellence, PTSD Center of Excellence, published stuff on that earlier this summer. And they actually have a symposium coming, I think in about 2 weeks, that are going to address it. It hasn't been part of what we have addressed currently, but we would work collaboratively with them and let them lead that initiative. Our focus has been primarily with veterans, but when you look at first responders and the others, this is a huge issue, and CIMVHR has been a leader in providing research for first responders. Our focus has been veterans.
All right. Ben, Friedhelm, do you have any comments? I mean, I think Jonathan Shea really was one of the originators of the notion of moral injury when he wrote the book Achilles in Vietnam. Any thoughts about moral injury as part of the construct?
Yeah, I will just say I think that's really critical, and in a lot of places across VA, I would say, particularly in the group setting, moral injury discussion, treatment, whatever you want to call it, is being offered as part of PTSD treatment. And I think it fits completely within kind of the whole health and biopsychosocial model, because if you think about meaning and purpose in life being front and center to how people deal with chronic pain or really any other problem, moral injury really gets in the way if you're not able to put it out front and address it. So I think there's quite an extensive network of those groups across VA already, and I would say over time, I hope that's going to grow together. It more exists within mental health right now, but I think bringing that together with kind of the whole health conversation is going to be really helpful for a lot of people. So.
Yeah, this weekend, I would also agree about the importance. I think there's no doubt about it. The question is really, how do you do this in a practical setting? Clearly, when I look at our pain management clinics and why they have fairly good penetration with behavioral health specialists, pain psychologists in particular, they're often, and I don't want to say overwhelmed, but that's not their focus necessarily. They develop more evidence-based protocols for CBT, for chronic pain, cognitive behavioral therapy for chronic pain. So our emphasis has been to work together with the mental health providers. Many of these patients have very well established mental health care within the VA system. I think it's something that we can rightfully be proud of as an agency, that we put so much emphasis and access to mental health care. And what we do is that we work in collaboration. We encourage our psychologists within the pain team to be really the liaison, the bridge to the mental health. There are some efforts to have a combined CBT for chronic pain as well as for PTSD. Basically have protocols that bring both components together. That's, it's done in Boston in particular. But we haven't really necessarily been able to get that everywhere so formalized. But the emphasis is really on good collaboration between mental health providers.
Thank you. Michelle, if it's okay, I'd like to turn to you. Again, we appreciate your courage in joining the panel. We've come to understand that chronic pain in those who served in the military and veterans and possibly, and I think likely true for anyone experiencing chronic pain, regardless of the source. The complexity derives in part from the highly personalized interactions that occur between physical injuries and emotional damage, both from the older events in the life of the individual person, as well as those that have led to the injury that may have spawned the initial pain, and the impact that both have on social and family relationships, especially if it involves the use of drugs and alcohol. Does this complex array that you've heard described in the biopsychosocial model, does this describe your own experience with chronic pain? And did unraveling these elements and peeling back all those layers into the roots of your suffering, did it represent a challenge for you, for your caregivers, for people like Dr. Zacharias and others that are caring for you now?
Well, until my military accident in 2004, I don't recall experiencing anything physically or emotionally traumatic. However, following my military injuries and several years of rehab, I no longer met universality of service and was subsequently medically released from the military. I felt like a failure, like I was weak. My injuries condition caused a relationship breakdown. I went from military medical care to having no family doctor at all. I spent the next 15 years trying to cope with worsening chronic pain while working full-time and single-handedly raising a family. Suck it up, buttercup, was the military expression that resonated with me, but my life was exhausted. I spiraled into a desperate need of help and contacted Veterans Affairs Canada and was referred to a pain specialist. Unfortunately, that appointment did not go well. I was subsequently referred to a different pain clinic where I had renewed hope and I would finally find some pain relief. Someone would finally help me.
So your experience at the outset of this, and it sounds like repeatedly for the 15-year interval, is very common to us. I think there are still service members that walk around with a t-shirt. I've got a picture of it in an airport once. Pain is weakness leaving the body. The notion that there's something inherently weak about people who experience pain, even though, as we know, pain was initially developed as a way of protecting us from recurrent injury. This is such a common notion. Have you come to an accommodation with that? Has that internalized, sort of stigmatized approach to pain been successfully rooted out? And what helped you do that?
I still feel weak, like a failure. I'm working on it. Every day's a struggle. Yeah, it's just one day at a time.
Well, I certainly hope that in some small, maybe minuscule way, this participating today has helped to validate that that's not the universal human response. And you certainly you're surrounded literally by people who have a much more balanced approach to that. And there's no weakness involved in.
I know, Eric, if I can just add one thing, Michelle currently has a provider out on the East Coast who has completely recognized her injuries and her trauma. So he will check in on her sometimes on the weekend to find out how she's doing. If he does any new therapies for her, he follows up with her. So I think it's a long ways from where she was about 14 months ago, where she had literally nobody in her community that she could turn to. But as Ben and Freedom and you and others who practice in this area, this is a challenge. It's a lifelong challenge. And so it's not one and done and you're finished. But I think what we need to, as practitioners and health professionals, realize is that but for the grace of God go I.
Well, I mean,
what would I want?
I think we all, I work with young medical students and have a lifetime of working with younger people who are much more agile and physically able than I am. But I know in small groups with them, in classes I've held in which we've interviewed patients, especially those who have lost a limb or eyesight or something, I've had students say candidly in a private discussion, gosh, if I ever had that happen to me, if I ever had pain like that, I would probably kill myself, because I couldn't live with that pain. I couldn't live with that level of disability. And I look them in the eye and I say, well, then I wouldn't grow old, because that's the experience of growing old. I don't run marathons anymore. I don't play rugby anymore. That's part of life. Our knees don't work the same way. And maybe we're not crippled to the degree by this pain that Michelle has been, but this notion of immortality and the ability to escape these in life is illusionary. Michelle, what would you recommend for us? And we're here in a listening mode. 2 or 3 things that you think that caregivers need to know about that would help us better understand the complex interactions that you experienced, and what things could we avoid? I mean, 15 years went by and encounters with caregivers that didn't go well. What things have you thought about we could internalize and do better?
Well, my first pain specialist appointment was one that I never want to repeat. The doctor who wouldn't make eye contact with me, shaking his head at me. He appeared rushed. He questioned, doubted, and dismissed my pains. After examining me for what seemed like less than 5 minutes, it left me feeling completely disrespected, deflated, hopeless, discouraged to ever seek or trust medical help again. I'm not in a position to give expert advice. However, after recently participating in the pain program at the Michael G. DeGroot Pain Clinic, I wish that caregivers themselves would participate in such a program. I feel that then, finally, there'd be a more wholesome understanding between caregiver and patient, and that itself, I think, would be good medicine.
Great. Thank you. And maybe it starts with good eye contact, which is getting harder and harder with the electronic health record, isn't it? Ben, you have a...
Eric, I just wanted to make a comment on that. Michelle, thank you for saying that, because one of the things we've discovered in VA is having employees, clinicians, everybody have the opportunity to be exposed to what it means to take this more whole person approach or whole health approach, like what it means if it is applied to them, is absolutely one of the most effective ways to change that dynamic and that conversation. And part of our sort of strategy over the next few years is really creating opportunities for VA staff and clinicians to have that experience. And I think you're absolutely on target that that's a really crucial part of the equation is helping people connect to what does this mean when I bring this to myself. I think that's a really important point.
Yeah, I don't want to make a plug here again for the Defense and Veterans, the U.S. Defense and Veterans Pain Rating Scale. But I think one of the things we've learned by that instrument is the notion of not chasing zero. That 0 to 10 pain scale, visual analog pain scale, really sucked us into the notion of we have to focus on a number, and we forgot the whole person in this. And I think what the jointly developed DOD, U.S. Department of Defense, and Department of Veterans Affairs, in fact, the VA and the U.S. had really been leading on this, developed was a tool that included the visual analog scale, but it linked every one of the numbers to a functional decline or a functional interference. And then when you flip the card over or you look at the other part of the scale, it begins to ask questions. How has this pain interrupted your sleep? How has it affected your activity? How has your mood been influenced by this? Is it a stress in your life? And it opens, as you were talking about, Michelle, a completely different dialogue than what we had been doing before. In fact, we naively, many of our clinicians, unfortunately, thought that they could be able to tell a patient how much pain they were in by what they observed as the level of what they thought was the physical injury. And we all know that pain is subjective. It's a completely subjective event. Yeah. We have just 5 minutes left on our panel, but there are a couple real quick things. I think this last discussion that Michelle has opened up with the perception of weakness and the stigma associated with it just addresses one of the questions that was posed to us, and that it was the focus on values. And I think looking at this, at the internalization or the perceived stigma associated with pain, and I don't know, Ramesh, if you have a comment about that, or you, Friedhelm, about how individual perceptions that may be internalized and impair their access to effective pain management or even receptivity to, as Michelle said, optimism that this is going to improve, influences that.
You want to go ahead, Freedom?
I think, a healing environment consists of multiple aspects, right? I mean, it is obviously a pleasant, welcoming clinic in many ways, and the physical structure itself, but it's even more so that it is a welcoming approach by everybody in the team who shows the appropriate openness, right? And I think what Michelle probably highlights and would say is that every person has their story, right? And while we're trying to use evidence-based algorithm to direct our care, we have to find out what is the story, what is the individual's, background and situation. And I think that openness, right, and that we open ourselves up to that story and find out of how we can help that person who's there right with us in that clinic setting or whatever it is, right? I think that is something that we universally need to have. And if you use that approach, then I think that stigma to some degree just goes away.
Eric, if I can just make two very quick comments. Many years ago, I was quite actively involved in emergency medicine. And I remember listening to somebody who was one of the program directors at UCLA, and I don't know if they're still doing it, but before you finished your residency program, you had to go be a patient in a community that nobody knew you. You had to come in with symptoms. You had to get an x-ray. You had to get blood work. So whatever you came up with required blood work and an x-ray. So you had to lie on your back, go on a stretcher into an elevator. It was the concept of, because nobody knows you and they just treat you as anybody else, how are they treating you? And it was a very powerful lesson for their residents. I don't know if it is continued now, but I think Michelle has touched on it. The idea that nobody believes me and you can't see what I suffer equates to you don't suffer is incredibly, incredibly powerful. I recall, I often quote what Gandhi said and what Martin Luther King said. Every society will be judged by whether they gave a voice to those who had no voice. Pain sufferers have no voice today. They're treated as malingerers, and that, why are you constantly coming back? And part of it has been, we have created the problem. We have given acute injuries opioids, and then years later, they become addicted. I'm also a coroner, investigated all these opioid-related deaths. And you say, where did this all start? So in Michelle's case, I think what comes out loud and clear to me was just believe what they're saying, trust them. And I think if you treat them the way you want to be treated, the way you want your kids to be treated in another environment or yourself, I think that's a good measure to say, how would I want it? And how am I going to treat the people I see?
Great thoughts. Yeah, many of us who enter into medicine and nursing and other allied health fields, we come with some heavy biases about how much we can control. And sometimes I think these dialogues are more about our loss of apparent control, and our anger is deflected to the patient themselves. They become doubly victimized by it. And when you, Michelle, show up and you say that what we've tried isn't helping, it collides with our armor of wanting to control. Very insightful and very helpful. I'm going to have to close up the panel. This has been really, really rich, and I thank you all for participating. You, Michelle, for the courage in coming in to an international conference with a panel of new friends here. But thank you all for that. We've had an opportunity today to learn that despite this long history of pain in humans, really to the dawn of time for all living organisms, we are still in our infancy in providing the best, most comprehensive person-centered care for chronic pain sufferers. We've learned that Canada and the US shares many issues in common in best managing the pain of our military members and our veterans when they become veterans. But we are both adopting progressive systems based on a patient or person-centered approach that tailors care for the individual, beginning with self-care and involving the entire array of practitioners from the primary care level to highly specialized clinics in a coordinated fashion. We are mutually committed to adopting a biopsychosocial model of care and of listening to the pain sufferer, represented today by our friend and our pain sufferer, Michelle, and the needs of caregivers at all levels about how to adapt a growing kit bag of both traditional or complementary practices like acupuncture and meditation, yoga, tai chi, qigong, chiropractic, medical massage, and others that are more with the more conventional approaches that use drugs, that include perhaps cannabinoids in the future, while avoiding opioids and other potentially injurious approaches that have spawned a second pandemic of addiction and injury in both of our countries. I have great optimism about the way ahead, and I thank our speakers today for this remarkable presentation. Again, CIMVHR and the CPCOE are to be congratulated for their role in bringing the U.S. Veterans Health Administration together with them today. And we hope this has been informative and we can continue this dialogue. Thank you all.
To all our participants, thanks for joining us in this week's symposium. Lieutenant General Schumacher, thank you once again for your leadership in the area of chronic pain and for helping us connect the dots today. To our U.S. colleagues, Drs. Sandbrink and Kliegler, thank you for informing us on what's happening with chronic pain at the USVA. And Dr. Zacharias, CIMVHR is thrilled to be working with you, and we look forward to continuing to advance chronic pain research with you and your center. Private Bourdon, thank you for your courage to share your story with all of us today. We appreciate you being here with us. Before we go, I just want to add that we are grateful to our presenters for sharing their expertise on this emerging topic that will undeniably continue to advance. Thank you.